TopMedTalk.
Welcome to TopMedTalk. I'm Mike Grocott, and I'm here with my co-host, Kate Leslie.
Hi,
Kate,
Mike.
how are you?
I'm well.
Tell me about the IARS, which I've largely missed due to travel fiascos, but how's the meeting been for you?
Terrific. Well, the IARS is the International Anesthesia Research Society. It's been in existence for decades. It's the publisher of anesthesia and analgesia, and they're meeting in collaboration with the Society of Critical Care Anesthesiologists here in Honolulu in Hawaii. I've been here since Thursday when I came to a pre-conference workshop. Now it's Sunday, so the meeting is closing around now at lunchtime. So in this podcast, we're going to update you and our listeners on some of our highlights, and we're lucky to have our emeritus editor-in-chief, Professor Monty Mythen.
It's good to be here.
How's the meeting been for you, Monty?
It's been great. I love the IRS meeting.
What was your favourite session?
Well, I was in the workshop as well that Kate was referring to at the beginning about the clinical trials workshop. And I think, as you both know, many people know, I transitioned to a position in industry, went to Edwards Critical Care a couple of years ago. We were acquired by BD, so BD Advanced Patient Monitoring. But I was delighted to be invited wearing my emeritus professor hat at UCL to speak about how to interact with industry partners. I've learned quite a lot in the last couple of years about how to collaborate more effectively, and also some views on international clinical trials. Really enjoyed it.
What were your takeaways from that?
My takeaways? Well, so it was good that we had the discussion. There was lots of great reflections. Interesting about the majority of the examples that we had to discuss were OUS, if you see what I mean. So the Australian examples, I think, really, that's most of what we spoke about, combined with some Canadian examples. There was relatively little to talk about from the point of view of what had happened in the United States of America. And that's part of what we got around to discussing about why the enormous potential, the data potential in the United States of America seems to be a little bit judgmental, relatively underexploited from the point of view of conducting the sort of trials where you think you could unleash that data power to answer some questions.
And is that, there's no shortage of academic departments in the US and not that much shortage of money for research. Is that a structural challenge?
I think that's part of it. I think the MPOG, for example, the Multi-Center Perioperative Outcomes Group, which is a collaborative grouping of some extremely well-known hospitals, has the potential to do that. And I think they've started to travel that journey. But unless I've missed it, Kate, I haven't seen any published examples yet of answering some of the sort of fundamental questions in large pragmatic trials.
Not yet, but they have started the Thrive study, which is a very large randomized comparison of propofol and volatile anesthesia on important both medical and patient-centered outcomes, and it's embedded in the MPOG registry. So this is one of the ways forward for clinical trials, is to use data that's already being collected. And we've talked about this quite a lot on TopMedTalk before, as well as about platform trials, which are familiar to listeners because of what happened during the pandemic with the recovery platform trial. These trial designs are much more efficient ways of using precious money moving forward. But you gave a great talk in the trials group meeting, Monty. It was about industry funding for research. You were describing two different sort of situations of industry funding. Perhaps you could tell us about that.
I started off the whole thing by explaining how rapidly I've learnt in the last 2 years. And part of that was a sort of decoding of the roles in industry. And a discussion they quite often talk about is the division between church and state, which often translates more in the United States of America. I listed on one slide the sort of things you might be familiar with marketing, sales, supply chain, etc. Then the other side of the slide is the bit I'm more involved with, which is so-called medical and clinical affairs. And that in itself is sort of unusually codified to most people. What does that mean? Well, the clinical affairs bit of it is more to do with the industry-sponsored studies. And sponsored in that sense, we understand what that means, but it's not just about the money. It's about the governance and safe conduct of the study and the indemnification of non-negligent harm, so the insurance around the study. And quite often, those trials are about getting regulatory approval. So in other words, getting the product through the regulatory body, for example, the FDA or the European equivalent or the Australian equivalent. And for devices, they're scientifically often relatively dull, because what they're doing is taking a great new piece of technology, trying to determine that it does what it's supposed to do and that it's safe.
There's a perception out there among clinicians that it's easier to get a device through the regulatory system than a drug. It costs less, and that you have to really prove that it's not going to blow up in the operating room as a sort of baseline? That's obviously a gross misperception?
That certainly used to be the case, is that when myself and Mike started first being on workshops back in Europe about this, one of the surprising things to me was most of it was about the robustness of the equipment, the height you could drop it from, electrical safety, whether the package insert was translated into the right languages, etc., and relatively little about whether the device could accurately, reliably do something that was worth doing. Well, that bar height's gone up considerably. It's not gone up as far as drugs, but it's gone up closer to drugs. So therefore, it is a long and very expensive process to get a new device, particularly if it's completely novel, to market.
Because in the last 25 years, there's been very few new drugs in anesthesia and lots of new toys, ultrasound, video laryngoscopes, new types of monitoring, hemodynamic monitoring, etc. So there has been that stark contrast.
Well, I think one of the differences there is you're often working, once you've got something approved, like an ultrasound device, for example, you hear people quite often talk about predicates. So if you can say, I'm now going to make something that is a better mousetrap. So in other words, it's going to be an ultrasound device that does at least what was done before safely and effectively. But now I've added some additional twists to that, some ergonomic changes, the depth of the signal, the interpretation of it on the screen. That's where you make the steps forward. And that's easier to make those steps forward than it is to continually make novel drugs. Therefore, you're continuing to advance in a way that is step by step by step.
We heard about a novel drug actually at this meeting, suzetrigine, which has just been approved by the FDA for use in acute pain in adult patients. It's a sodium channel blocker that works peripherally. It's asserted that it's equivalent to opioid drugs in potency. So that's the first new, really different mechanism drug in pain that we've had for a while.
And then we've had remimazolam,
Yes.
the sedation perspective. And I think we've had misalpride, which is a repositioning of a drug for rescue antiemesis, for example.
Yes.
So there's not nothing going on, but it's been a
No.
while until we've had these little step changes.
But what has happened in the last 25 years is the repurposing of a bunch of old drugs, ketamine, lidocaine, clonidine. At the trials group workshop that we went to, we also heard some great presentations from some established and emerging research leaders. The chairs of the workshop, Elizabeth Whitlock and Ron Pearl, selected 4 fantastic abstracts. And one of them was from Dan McIsaac, a professor of anesthesiology in Ottawa, who told us about his PREPARE trial. And we interviewed him today on TopMedTalk, so you can go and listen to that podcast. And then there were 3 terrific abstracts from emerging researchers. Did you enjoy those, Monty?
I did, including medical students.
Yes.
Very impressive.
There was a terrific one about sugammadex, neostigmine, and urinary tract problems. That was great. The rationale behind that was that neostigmine, as an anticholinesterase paired with glycopyrrolate, an antimuscarinic agent, might cause urinary retention post-operatively, and that if you use sugammadex instead, you might be able to show a difference in the rate of catheterization in the PACU and other endpoints. And it was a pilot study, and it showed a small difference.
It did.
Yeah, so that was exciting.
And you're doing a big study in that space, aren't you, Claire?
I am. We are, I should say. It's called SNAP. It's sugammadex, neostigmine, and postoperative pulmonary complications. And it's March now in 2025, and we'll have finished follow-up in October of 2025.
And did you look at these sort of outcomes as well?
Not this one. The focus of our group, and actually trials groups worldwide, is to have a parsimonious data set, because the more you ask our trial coordinators to collect, the more expensive it is and time-consuming and burdensome on the patients. So unfortunately, we're not collecting that particular outcome.
Could you go back, given that this is a procedure that's usually done by someone documented in the United States, charged for, and certainly timed, could you maybe go back on a subset of those or even all the data and have a look?
We could, and that would be a great project for a young researcher with an interest.
I mean, MPOG could probably answer that question.
They probably could.
Yeah.
They probably could.
There's a wonderful data set they have, so they could probably explore that.
Yes. I went to another great session, which was about protocolization and personalization of healthcare and anesthesiology. The first presentation was about the importance of following evidence-based guidelines like IARS protocols. But then the next presentation was about how if you rigorously follow that, you lack the personalization where the anesthesiologist might identify patients who have special needs. A lot of the guideline development that we've seen is based on a restricted population of patients in academic medical centres. The first presentation was by Dr. Girish Joshi from the University of Texas, and the second was from Dr. Kristen Schreiber, who's from the Brigham and Women's Hospital. And Kristen in particular was talking about the use of biomarkers and genes and so forth to predict how patients might react to different things that we do. So that's coming to a operating room near us in the future, Monty.
And did they conclude that the both could live together? Sorry, I missed the session. It was one of the things I was hoping to get to, but
They did, yeah. So that, slavishly applying an algorithm which is outdated the minute it's published and which highly likely didn't, include a patient that is similar to the one in front of you do. We use a guideline, hopefully, as a jumping off point to optimize and personalize care.
I think we've seen that in the enhanced recovery developments over the decades. There was a point at one stage where people were saying, let's take multimodal analgesia, for example. Can I have your drug and dose recipe? And the conclusion after that was to say, no, the principle is multimodal analgesia. You should do what is right for the patient in front of you. So if they're an elderly, frail patient, a gabapentinoid is not necessarily going to be in their best interest if they're having Operation C. So it was the principles as opposed to the drug and the dose.
Excellent. And what else did I miss?
Well, I went to another great session that you were supposed to talk in, actually. It was about prehab, and Monty and Mike in particular have got a long history of research and interest in that area. I'm new to the area, but I've heard a lot about it recently, and Mike and I were actually at the World Congress of Prehab in Melbourne was it September, October or November?
In November?
Yeah.
The next one, shameless plug for the International Prehab Society, will be in Vancouver in November of this year.
Oh, that will be good.
Yeah, hosted by the University of British Columbia.
Where do we find the details for that, Mike?
That will be on the International Prehab Society website, and we'll put it in the show notes for this recording.
So this one was chaired by Dan McIsaac, this session, and Dr. Sandy Jackson gave Professor Grocott's talk for him and did a beautiful job, and that was about exercise.
And this is properly confusing because my talk contained data from Professor Sandy Jack, who's a lady scientist, and it's being presented by Dr. Sandy Jackson, who works in the same department and causes us endless confusion all the time.
Yeah.
But,
and is not Sandy Jack's son.
No. But did a great job, I hear.
So what were the key takeaways from that talk?
Well, I wasn't there, but if he used the slides that I sent him and didn't change them too much, the talk was focused on exercise particularly. So there were separate presentations about nutrition and psychology, and maybe we can get onto those in a moment. I think the basic messages, some of which we touched in our interview with Daniel McIsaac, are it does appear that exercise has benefits, and that's not really very surprising. The broader talk covered a lot of the epidemiological data, so there's overwhelming and long-standing epidemiological data that either physical activity, so just doing stuff with your muscles, going for a walk when you feel like it, or exercise, which is the planned, programmed, structured type of physical activity, improves outcome. So it decreases your likelihood of developing almost any physical or psychological psychiatric illness, and it improves outcome from that illness if you start exercising once you've got the illness. And the data is extraordinarily widespread and long-standing, and I think we all know that, but I think sometimes it's easy to forget. In our particular space, the structured aerobic exercise programs before surgery clearly, one thing that's very striking experientially is patients love this stuff, maybe a little bit surprisingly, but they really seem to enjoy being involved in these exercise programs. The patient experience quality of life measures are overwhelmingly positive in just about every study I've seen.
And is that because they like having the interaction with the therapist and having coffee with the other participants afterwards, or do you think they actually like the exercise part?
I don't think they necessarily like the exercise. I think quite likely some of the social interaction, but the message they give is one of empowerment.
Right.
So in a context where they are relatively disempowered because they basically get told to turn up to various appointments, have these drugs, have this operation, they can do something to potentially change what subsequently happens. And that really seems to resonate with them. We talk about the teachable moment. The problem with exercise, which is what we touched on with Dan McIsaac, is outside of a face-to-face in hospital or perhaps community setting where you can ensure that adherence is very high, how do you effectively disseminate this to large numbers of people in the pre-surgical context? And that's proving more challenging.
And that theme moved through to the other two talks in the session. Chelsea Gillis told us about diet and nutrition and the post-operative space. You know quite a lot about that. You could probably summarize her talk without having been there.
I don't know exactly what she said, but I suspect she said it's massively underdiagnosed, and I've seen their data. Ours reflects similarly. If you start deliberately screening for nutritional deficits, you find them probably double the rate that they are clinically identified. And then I'm sure she talked about some of the things you can do to sort out individuals who are high risk, including protein supplements, different types of dietary interventions, macronutrients.
She was actually emphasised strength training, in particular in frail patients. You just mentioned aerobic training. So that was interesting. And then the third...
Which is interesting because I think most people believe it's the right thing to do, but there's almost no data.
Oh, really?
All the bigger multi-center studies use either exclusively or predominantly aerobic training. So although we always go exercise and strength training, and it makes perfect sense in terms of muscle mass and mobility and avoiding disability, particularly in older people, the data is much less compelling than it is for aerobic training. So I'm not disagreeing with her, but it's surprising how weak the evidence is in that area.
And the resistance component, Mike, because there was in the story at one stage the importance of resistance, which would be hard to avoid developing strength.
So resistance strategies, they're generally wrapped up together, and that's where there's much less data.
So that's riding a bike rather than running.
No, rowing, swimming, longer duration aerobic, and they're often done using a kind of interval training approach, higher intensity, lower intensity over 1 or 2 minutes, for example, as opposed to deliberately doing strength-based resistance exercises to try and build up muscle bulk.
I just want to ask one thing about Mike, because we're listening to some of the results from Canada that were presented. And I didn't see it published yet. Do we get
Not yet,
out the back
but we can talk about the results.
So my takeaway from it was their endeavours did not produce a difference in outcome. Part of the reasons they chose to do the exercise the way they do it, by my take, was because they're dealing with a very remote population. We're trying to bring people together in a local church to have supervised training, whereas the data I've seen from you in the south of England, it's a very different challenge from the point of view of, the most remote part of Wessex is just not very remote, is it?
No, I mean, we discussed this with Dan earlier. They were talking about people who were 60, 70, 80. I think their median distance from a cancer centre was 60 kilometres. And for us, I mean, the population density is very different in Canada than it is in the United Kingdom. And for us in the south of England, it is feasible and possible to achieve high adherence by using local community gyms. There's enough community gyms around where the people are. So it's not to say that there aren't a few people around in the countryside living on their farms, for example, but they're probably used to going into town anyway to pick up the shopping.
So do you have a way now of factoring that in, or are you starting to factor that in, that when you show us the results, you have some sort of adjustment that says this is a low density, remote distance to 6 feet of snow environment, very cold compared to sunny Wessex?
No, but I think it's not a factor we've particularly focused. I mean, Dan and the other guys in Canada have been aware of it, but it's not been a factor, the sort of geospatial mapping type approach.
To try and put the results in context.
No, I mean, we did discuss about, you both have to individualize to the patient, but you may have to individualize to the context as well, but particularly, rural Australia and Canada being particular examples.
Yeah, and the final talk in that session was from Dr. Jim Jackson, who's from Vanderbilt University, is a neuropsychologist. And he comes from a background of rehabbing people with traumatic brain injury or with mild cognitive impairment using cognitive brain training, exactly, and how results of that have been disappointing. And, it's the same thing. It's an implementation problem. So he's moved to talking and studying prehabbing people's cognitive function before surgery. And that was really interesting. The dose is quite high. that is required, and also the intensity. So, it doesn't work if you're watching the TV while you're doing or answering your phone. You have to sort of turn your notifications off. And then people are distractible and get bored easily. So, it needs to be infinitely variable and highly engaging.
It kind of fits with the physical exercise data, though. The dose is significant. If you look at the interval training interventions that have proved successful in terms of demonstrated ability to improve measured physical fitness and then translate that through to outcomes, they're not trivial in terms that the patients are spending 30, 40 minutes 3 times a week, for example, doing what is quite hard work. Good. So,
can I just comment on the abstracts?
yes.
Because there are close to 1,000 abstract submissions here. And the way that the abstract sessions are done is there's a limited space where you rotate through having, let's call it old-fashioned paper abstracts up on a board that you can walk down the corridors of them. But they sort of seem to be put up at about 100 at a time. It was a joyous experience to go back to the ability to see every abstract.
Interesting. So all the technical innovations to try and make that paper-free and more slick have probably not been that effective.
I don't know. They had a bit of both, if you see what I mean. So you could go and also you can look at it all online yourself. They had a corner where you can look at the digital ones. But there was, I don't know, Kate, what do you think? I quite enjoyed the sort of, maybe I'm just old and fuddy-duddy, but the fact you could wander up and down quickly.
I enjoyed it as well, because you could wander up and down and see what caught your eye. And some of the more assertive investigators would collar you and say, can I tell you about this project about the bispectral index? Let me tell you about it. This was great. Actually, I really enjoyed it. And all of the chairs for academic anesthesiology in America were there. And it was everything from high school students to professors. And this is the sort of networking that we missed in the pandemic. I think we do miss it when the abstracts are up in a digital form for a short amount of time.
Interesting, not particularly studied area. Yeah, what the rate of follow-on collaborations is, because I suspect all of us have had the experience of standing in front of a poster with someone who 5 years later you're collaborating on a trial with.
So listeners, this is a free research idea that you can use without asking us for permission or including us. And we look forward to reading the results.
And you can come on TopMedTalk and tell us about them.
That'd be great.
Fantastic. So I think I've had enough of hearing about this wonderful meeting that I've managed to miss. We should probably wrap up there.
Another thing you can do is, if you're registered for the IARS SOCA meeting, you can find all of their oral presentations on their website and listen to them, watch them at home. And it might even be possible to register for the meeting after the fact and get access to some great material.
And the abstracts will all be published, I think, in Anesthesia and Analgesia in a supplement that sometimes takes a while to come out, the full supplement.
So I'm going to get registered for next year's IARS as soon as possible, which I think is at Montreal. In May, I think. Yeah. It's slightly later in the calendar.
But watch the abstract deadline. I've just noticed it. It's not long until the abstract deadline.
Good to know.
So have a look soon.
I'm going to do my thank yous. Thank you, Professor Kate Leslie. Thank you, Professor Monty Mythen.
Thank you.
Senior editorial team here at TopMedTalk. Thank you very much to our sponsors, without whom we wouldn't be able to bring all this material free to the world, and that's BD and GE Healthcare. You can find us on the socials, on X, formerly known as Twitter, on Facebook, on the TopMedTalk website, and on YouTube, where we have sound recordings, but you'll be delighted to know no videos. So, Monty, Kate, thanks very much. Thanks for informing me all about the IARS that I missed. Bye-bye, everyone.
Bye-bye.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.